Hi students, hope you're all doing good. So in the previous video on diabetes and pregnancy, we have learnt about what are the various types of diabetes and how diabetes is going to influence in pregnancy and what are the various screening tests. Now in this video, we are going to learn about the complications that can occur in the mother and the fetus and about the management. Clear? Right. Now we'll see the complications in the mother first. So complications in the mother. See, there can be early pregnancy complications like miscarriage. So, first one is early pregnancy complications like miscarriage, especially if that is a pre-gestational diabetes mellitus. Okay. And in pregnancy, she can develop, okay, gestational hypertension, or it can proceed further into preeclampsia, okay, and infections including urinary tract infection or asymptomatic bacteriuria or also vaginal candidiasis. Okay, and remember there can also be polyhydramnios in pregnancy. Why? Because hyperglycemia is also going to affect the fetus. So, the fetus is going to pass more urine. So, polyuria in the fetus, okay, that will be going to cause polyhydramnios because of polyuria in the fetus. Okay, and remember this fact that not only polyhydramnios, oligohydramnios is also possible in a case of GDM or pre-gestational diabetes mellitus, whatever. Because why? Because I already told you preeclampsia can occur. So, what is the cause of preeclampsia? It is uteroplacental insufficiency. So, that can result in oligohydramnios also. Okay. So, the next one, the complications in delivery include preterm delivery. Okay. So, this will be mostly iatrogenic. Okay. And there can be instrumental delivery or traumatic delivery. Okay. And most of the time they can end up in cesarean section also. Why traumatic delivery means the risk of shoulder dystocia is increased in diabetes. Okay. So, because of that the lady may end up in a traumatic delivery. And then postpartum, she can have increased risk of infections, okay, or postpartum hemorrhage. And there is also increased risk of maternal morbidity or mortality. Clear? Now, I also want you to know the long-term complications that the women can have. Okay, even if she is diagnosed as a case of gestational diabetes mellitus. Okay, there is a long-term chance that she may not lose the weight that she has gained during pregnancy. Okay, so weight retention can be there. Okay, and there is a higher risk of GDM in next pregnancy. Okay, and also she is at a high risk for DM in her future also. Okay, if you take, the risk will be as high as 50%. Okay, that is 50% risk. And she is more prone for cardiovascular diseases and also other complications of diabetes like nephropathy, neuropathy, retinopathy, whatever. Okay, so there is increased risk of nephropathy, neuropathy and retinopathy, especially if it is a case of pre-gestational diabetes mellitus. Clear? Okay. Now we'll see the complications in the fetus. Okay, very, very important. So, complications in the fetus. Okay, there can be congenital anomalies. Okay, if it is a pre-gestational diabetes mellitus. Okay, so congenital anomalies, and this is mostly seen in pre-gestational diabetes mellitus. Why? Because hyperglycemia is going to cause free radical injury in the developing fetus. Okay, so that will lead to congenital anomalies. And we know most of the anomalies are going to happen in the first trimester. So, it is most common in pre-gestational diabetes mellitus, okay, or a chronic diabetes case. Clear? But when it comes to the gestational diabetes mellitus, most of the organ systems would have formed in the baby, and so these congenital malformations are not seen in a case of gestational diabetes mellitus. But other complications can occur. But regarding congenital malformations or anomalies, it is not going to happen in the case of gestational diabetes mellitus. Okay, understand this point. So, I also want to tell about the HbA1c value. Okay, if you see the HbA1c value, if it is becoming more than 6.5, then there is a 3% chance of congenital malformations. Suppose if it is happening up to 9, okay, then the risk of congenital malformations increases up to 15 to 20%. Can you see the difference? Okay, here only 3% risk, whereas here it is increasing to 15 to 20%. Okay, and then now if we see the system, okay, so it is most commonly cardiovascular system which is affected more than the CNS. Okay, CNS means it is mostly neural tube defects. Okay, and among the CVS anomalies, if you ask me which is the most common CVS anomaly, it is vascular septal defect. Okay, so that is most commonly seen. But the most specific CVS anomaly for gestational diabetes mellitus or diabetes pre-gestational diabetes is TGA. Okay, then also one of the most common finding that you can see in USG. Okay, most common finding you can see in USG is hypertrophic cardiomyopathy. Okay, so hypertrophic cardiomyopathy. Okay, so this is one of the most common finding. Okay, but the most common anomaly you see is VSD and the most specific anomaly is TGA. Clear? Now, if you see this hypertrophic cardiomyopathy, it is going to be only a temporary finding. Okay, and it may resolve after birth. But however, we have to offer the fetus fetal echo. Okay, and this should be offered between 18 to 20 weeks of gestational age. Clear? So, especially in a case of nothing has happened means, okay, even if it is a pre-gestational diabetes mellitus and there is no complications also, you have to do a fetal echo at 18 to 22 weeks of gestational age. Clear? But if you ask me, okay, I told you CVS anomalies are more than CNS anomalies, and CVS anomalies we have discussed. So, if you ask me which is the most specific anomaly, okay, regardless of the systems, okay, whether it is CVS or CNS, whatever system. So, the most specific anomaly is caudal regression syndrome or sacral agenesis. Okay, very, very important. Clear? Right. Now, we will see the next complication that can occur in the baby, that is, already we have seen this, the baby can be macrosomic. Okay, so the baby can be macrosomic. that is macrosomia, baby is possible. So already I told the definition that the birth weight will be more than or equal to 4 kg, and during antenatal period if you see in the USG, the abdominal circumference is going to be more than or equal to 35 centimeter. Okay, and this complication is high when the blood glucose values of the mother are more than 130 milligram per deciliter. Clear? Now, the baby is macrosomic. What complication can you expect while delivering? Yes, she can end up in shoulder dystocia. Okay, there can be a chance of shoulder dystocia during delivery. And due to shoulder dystocia, obviously, nerve injuries can occur. So, Erb's palsy is possible. Okay, and other complications like respiratory distress syndrome can occur. Okay, and for this we can do lung maturity test. Okay, lung maturity test, the specific test what we do is detection of phosphatidyl glycerol in amniotic fluid. Clear? Then we can also have hypoglycemia in the baby after birth. I am talking. Okay. Why hypoglycemia? Because already we know there is hyperinsulinemia. Right? Then other conditions that can occur in the baby is there can be hypocalcemia or hypomagnesemia, and all these things can occur due to prematurity. Okay, and sometimes, yes, sometimes there can also be polycythemia and hyperbilirubinemia. This both can result in hyperviscosity syndrome. Okay, and there is an increased risk of fetal death or IUD in the diabetes mellitus. Why? Because as the baby grows, there is increased oxygen demand. Okay, but in the case of diabetes mellitus, there is a state of hypoxia developed due to the vasculopathy or placentomegaly, whatever is happening. Okay, so due to this hypoxia, there is decreased fetal oxygen levels as well as fetal nutrition is also reduced. Okay, but however, if this becomes sustained for a long time, okay, then it will end up in fetal death. Clear? And especially this happens during third trimester. Okay, that is the worst part. So, it happens more during third trimester because the fetal growth demands are going to increase during this third trimester. Clear? Now, we will see how we are going to manage the condition. Okay. So, always the management starts with preconceptional counseling. Okay. So, we have to give preconceptional counseling. Okay, mainly to reduce weight. Okay, so to reduce weight, okay, and to maintain a normal BMI levels. Okay, you have to advise some changes in diet and lifestyle. Okay, and if you see the management in pregnancy, okay, so management as such in pregnancy means, remember your target glucose levels, okay, are going to be, already we have seen, right? So, the fasting blood glucose level should be less than 95 milligram and 1 hour value should be less than 140 milligrams and 2-hour values should be less than 120 milligrams. Clear? Okay. Suppose she has got any deranged values. Then our first thing that we have to advise is diet. Okay. So that is also known as medical nutrition therapy. Okay. So that is known as MNT. Okay. So here we have to adjust the calorie intake. So the calorie intake, if she is a normal weight woman, you have to maintain it between 30 kilocalories per day. Okay. And if she is a overweight woman, the calorie intake should be around 24 kilocalories per kilogram. Sorry. Okay. And if she is a morbidly obese woman, then it should be 12 kilocalories per kilogram. Okay. So ideally, we are going to divide her meals into 3 meals and 2 snacks. Okay. And this should cover carbohydrates up to 40% and fats should make up 40% and remaining should constitute the proteins, which will constitute another 20%. Clear? Now we will see about physical activity. Okay. So physical activity means we have to advise her moderate intensity exercise. Okay. So moderate intensity exercise, especially aerobic exercise, can be advised. Okay. So that should be done 30 minutes for 5 days or 120 minutes per week. Clear? So, better glycemic controls, okay, can also be seen with walking. Okay. So, remember, it can also be seen with walking, and that should be done 10 to 15 minutes after meal. Clear? So, this is the first thing we are going to advise her. Okay, medical nutrition therapy, that is diet and exercise. So, I have a pregnant woman with GDM. Okay, and I have offered her medical nutrition therapy and exercise. Now I will check her 2-hour postprandial blood sugar levels. Okay. Suppose if it is less than 120 milligram per deciliter, then we can continue MNT and exercise. Okay. Suppose if it is more than 120 milligram per deciliter, okay, then we have to start either insulin therapy or oral diabetic therapy. Clear? Now, even if we start this, what we have to do is, so we have to check fasting blood sugar levels and 2-hour postprandial blood sugar levels. Okay. If you are giving insulin, that should be done every 3rd day. Okay. Suppose if you are giving oral antidiabetic, sorry, it is oral antidiabetic. So, if you are giving antidiabetic like Metformin, then at least it should be done once in 2 weeks. Okay. And then you have to do dose adjustment as needed. Clear? So, this is how the MNT and exercise is going to help. Okay. So, now we will see this pharmacotherapy. Okay, so in pharmacotherapy, pharmacotherapy is usually preferred as a first line management in less than 20 weeks of gestational age. Okay, so remember, always insulin is the preferred agent of choice in pharmacotherapy. Okay, and so this is usually started when MNT and physical activity is not going to work out. Clear? So that means blood glucose levels should be more than 120 milligram per deciliter, especially the 2-hour postprandial blood sugar levels. Okay, and usually insulin dose should be individualized. Okay, but the starting dose of insulin can be anywhere between 0.7 to 1 units per kilogram. Okay, and you can split this dose as 2/3 dose in the morning and 1/3 dose in the evening. Clear? So you can give short acting insulin analogs than regular insulin, but these are expensive. Okay, so insulin should be ideally taken by a subcutaneous dose 30 minutes before food. Okay, so always self monitoring of glucose levels should be advised to the patient. Okay, should be advised. Okay, even after 2 weeks, okay, of reaching normal values. Okay, okay, at least 3 times she should check her sugar levels. Okay, one fasting level and after each meal. Okay, 1 hour and 2 hour values. Clear? Next we will see about oral hypoglycemic agents. Okay, so oral hypoglycemic agents. This is usually done when the patient has a poor compliance with insulin because she has to take multiple injections. Okay, and there is a need for self-administration of injection, right? So if the patient is not comfortable with that, and there is a need for frequent glucose monitoring also, as we have previously discussed. Okay, so frequent glucose monitoring also. If the patient is not comfortable with any of these things, then we can put her on oral diabetic agents, anti-diabetic agents. Okay, so Government of India guideline says Metformin is the first line of treatment given when the gestational age is more than 20 weeks. Clear? Now we'll see about Metformin. The dose is 500 milligram HS for 1 week. Okay, if needed, you may increase 500 milligram BD also. Okay, so the maximum dose of Metformin you can give is 2500 to 3000 milligram per day. Okay, and this should be given in 2 to 3 divided doses. Clear? So before giving this, remember to check the baseline creatinine levels. Okay, and also side effects like abdominal pain and diarrhea are associated, so you have to advise them to take it with meals. Okay, take it with meals. Clear? And then another oral hypoglycemic agent I want to discuss, that is glyburide. Okay, So, the starting dose of glyburate is 2.5 to 5 milligram per day, and maximum dose you can give is 20 to 30 milligram per day. Okay, and it should not be substituted for insulin anytime. Okay, now if we see the obstetric management, okay, so obstetric management. So we'll see when the termination of pregnancy should be done. Okay, so termination of pregnancy in a case of A1 GDM is done around 39 weeks to 40 weeks plus 6 days. Okay, then in a case of A2 GDM, you have to do it at 39 weeks to 39 weeks plus 6 days. Okay, so these are given in the guidelines. I can't help. Okay, you have to remember this. And for a case of pre-gestational diabetes mellitus, okay, if it is a well-controlled condition, then you can terminate it around 38 weeks. Okay, and for a poorly controlled condition, you have to terminate it around 37 to 38 weeks. Okay, and usually cesarean section is not indicated in any of the things other than fetal macrosomia. Okay, cesarean section is indicated only in cases of fetal macrosomia for the fear of shoulder dystocia and traumatic delivery. Otherwise, usually we prefer vaginal delivery. Okay, or any obstetric indications, any other obstetric indications, but as such vaginal delivery can be preferred. Okay, so if the patient is in labor, what we have to do is we have to withhold the morning dose. Night dose we can give, okay, but we have to withhold the morning dose. Okay, and 2-hourly plasma glucose monitoring is needed. Clear? And then you can give regular insulin in normal saline. Okay, so the rate of giving the dose will be 100 milliliter per hour. Okay, and if we see the dose requirements, it depends upon the glucose values, right? So up to 120 we are not going to add any insulin, but between 120 to 140 milligram per deciliter we have to add 4 units of insulin, and 140 to 180 milligram per deciliter we have to add 2 units of insulin. This is okay, units. Okay, and more than 180 milligram per deciliter means we have to add 8 units. Clear? And we'll see how the fetal monitoring should be done now. Okay, so this is all about the mother. So we'll see the fetal monitoring. See, early in pregnancy itself, when you confirm her to be a case of GDM or DM, whatever it is, you have to advise her daily fetal movement count. Okay, this even she can do it at her home. Okay, and you have to do NST twice a week. Okay, and modified biophysiological profile, that is including AFI by ultrasonogram twice a week. Okay, and in the USG we are going to keep a check on the fetal growth. Okay, as well as I have told already, polyhydramnios or oligohydramnios. So it is generally the amniotic fluid. Okay, so usually Doppler in pregnancy is not needed. Okay, so you offer Doppler in pregnancy when you suspect there is some uteroplacental insufficiency. Okay, clear? Now, so we'll see the postpartum follow. Okay, so what you have to do is, if you have started her on insulin, you have to stop that insulin soon after delivery, and this should be converted to oral hypoglycemic agents after delivery. Clear? And women should be advised on the postpartum diet, yes, then exercise and lifestyle modifications after delivery. And see, glucose levels should ideally be checked once when she is in the in-hospital condition itself. That is, it should be checked at least at 24 hours after delivery. Okay. And ACOG recommendation is to offer a 75 gram GTT between 4 to 12 weeks after delivery. Okay. And also remember, if you are advising contraception, the contraception of choice in diabetic women is intrauterine device. Okay. So with this, we are completing diabetes in pregnancy. So until we meet in the next video, keep going, happy learning and take care.